Thank you very much. So I'm Emma Bradley. I'm a community paediatrician in Bristol, and I'm also the designated doctor for safeguarding children in Bristol. This is Michelle Cutland. Do you want to introduce yourself?
Yes, I'm Michelle. I'm a consultant paediatrician as well, and the clinical lead for the children's bit of the Sexual Assault Referral Centre that serves Bristol and the wider community.
And Stephen.
I'm Stephen Barry. I'm the clinical lead and manager for a service called Be Safe. We're based within the specialist CAMS in Bristol, but we also cover South Gloucestershire for 7 to 11-year-olds. And my background is a social worker and integrative psychotherapist.
Okay, so we've been asked to talk about busting the myths associated with child sexual abuse. So we thought we'd tell you what we know about sexual abuse, what the evidence base tells us. So we're going to think about the who, the when, the what and the where. We're going to think about children's disclosures. We're going to think about the role of the health professional on the child sex abuse pathway. And we're going to think about people who carry out sexually harmful behaviours, both adults and children. And then finally we're going to think about what impact this has on young people and their futures. Okay, so who are the children that are sexually abused? We've already heard quite a lot about that from our colleagues. Lots of people will believe that child sex abuse happens to other people. It's not the people that we know, it's not our friends, and it's not children who live in the same social demographic as we do. The reality is that child sex abuse happens in any child, in any family. There are statistics that will tell us that some children are more at risk than others, but it's important to remember those are just statistics. People often think it's only girls that get sexually abused. We know that 15% of girls are sexually abused, but 5% of boys are. That's what the evidence tells us. So actually it's really important to think about these things when we're seeing children and talking to them. Vulnerable children. Some children will be more vulnerable than others. They may be living with adversity like parental mental health illness, parental substance misuse, living in extreme poverty. But actually all of those things are only, sorry, not poverty, but the adversity means that they can be more at risk of child sexual abuse can happen more to those children, but it's not a done deal. It happens in every strata of society. Ethnicity, sexuality and disability. We don't think that sexual abuse happens in any ethnic groups or any different cultures with any different frequency. But what we know is that we haven't got all of the research base to tell us that. And we also know that for some young people, it can be very hard for them to access the right support to get their voices heard. Okay, the when.
So I'm going to talk about the when, and basically these slides are just to kind of some of the things you think you might know about sexual abuse. We're trying to kind of raise those to sort of, confirm or kind of maybe challenge some of those thoughts that you have. So when, so a lot of, one of the things is about age. So I think when people think about children who've been sexually abused, they might picture a primary school age child as that's the kind of child that would be sexually abused, the kind of age. And children of any age can be sexually abused. When we think about indecent images of children, according to the Internet Watch Foundation, for example, 1% of all the images they see are children under the age of 2. So we're talking about very tiny children, and often those images are the most severe category of images. So very small children, pre-verbal children, do get sexually harmed. When we're thinking about self-generated imagery, again, the Internet Watch Foundation, the research that they've got and the data they've got, that tends to be 7 to 11, sort of 12 to 13-year-old girls primarily. In my service at the SARC, the sort of two peaks of children that we see within our service are the 8-9-year-olds and the 13 to 15-year-olds. And that also reflects what is seen when adults are asked about when did your abuse first start. The most common age that adults tell us their abuse started is 15, followed by 12, followed by 8. But of course, remember, some little children and pre-verbal children may not remember as well, so we don't really know what is happening in that age group. When we're thinking about when as well, people sort of, again, might think, well, abuse is something that happens over many, many months. It can be one event, it can happen once, it can happen many times. So that's just some of the kind of detail about when. Oh, it's me again now, isn't it? Yeah. A little bit about what as well. So this is the Department of Education definition of what sexual abuse is. It's a bit wordy. It covers, I think it's not bad, it covers all the kind of different types of sexual abuse, whether that's contact offences or indecent images or technology assisted. So I think it's not a bad definition. again, when people think, they might think, well, sexual abuse is a contact offence. It's something, they may think rape is sexual abuse. That's what sexual abuse is. But it has many, many forms. And what I think is important to remember is no one form is any less impactful than another. We think, and the research sort of tells us a little bit, that some particular features of abuse may be more impactful. And kind of some of the key information about that is about how long it's gone on for, and in particular around the relationship between that child and the person who sexually harmed them. What I think is really important as well is to remember that if we think that different types of abuse are, if we rank them in our minds, that will impact on how we respond to children. So it's really important that we respond to children in the same empathetic, sensitive, caring, hopeful way as whether it's a child who was raped 3 hours ago or it's a child that's only just told about rape that happened 3 years ago. It's right that you get the response the same across the service, because for that child it really matters that that response is reactive and timely and thoughtful. The other thing is about child sexual exploitation. Again, some people think that's very different from child sexual abuse and they kind of put it in a different box. But as Jane and Liz have identified, it is a type of child sexual abuse. It is not different from child sexual abuse. It is a type of child sexual abuse. And actually one of the most common features in children who've been exploited is prior trauma. And a fair chunk of them, that prior trauma has been sexual abuse of a different kind. So to understand child sexual exploitation and respond to it, you definitely need to understand child sexual abuse in all of its guises as well. Me next as well. Yeah. Where? There you go. So where do children get abused? Again, people might think, oh, this happens in the family home. That's what it is. And actually, much of it does happen in safe spaces, including the child's home. Sometimes people think, well, parents would surely notice if a sibling or an abusing parent was doing this. They would see it happen. They would know. But they don't know. Some abuse can be very opportunistic. Some people who harm children take risks. Some siblings may abuse in one room while mum's making dinner in the other. So we can't make any assumptions about thinking that non-abusing people in the house would notice, because it can be very opportunistic and some people take risks. Peer-on-peer abuse, sadly, often takes place at school, and those of you in education will know that this is what happens. So we do see sexual harm happening in school and other educational settings. It can take place online, and a significant number of offences do. And we mustn't forget that institutional abuse also occurs. So children can be harmed in places that should be safe and should be therapeutic and should be fun. So children can be harmed in schools, they can be harmed in hospitals, they can be harmed in sports settings and in religious settings as well. So it's just keeping your mind open to the broader settings and places where children can be harmed.
Okay, so something that we quite often hear is that the children need to tell us if they're being abused, and we can't do anything about it until they do. So we know that children find it really difficult to tell people what's happening to them. Sexual abuse by its nature is very secretive, and often children will have been threatened that if they tell someone, something bad will happen to the rest of their family or their friends or their dog. They may believe that what's happening to them, they may be being told that it's because they're special, they're the chosen one, and it may also be that their perpetrator has befriended the family, and there's a risk that if the perpetrator gets found out all the nice things that that perpetrator brings to the family, like trips or money or time or making parents happy, that might all stop. So they can feel a real weight of responsibility not to tell. So we need to listen to the children in every sense, not just in the words they're saying, but in how they behave, how they're interacting with others, and also pick up quickly on any cues that they're giving us. It's really important that we don't wait till they tell us in words what's been happening to them.
So safety is really important to children as well. We know, and you all know, that sometimes children don't feel able to talk about what's happened until they're safe. And that might be a physical sense of safety, it might be the home that they're living in. We know that sometimes children are maybe placed in a foster care, and it's 6 months down the line they're then able to talk about what might have happened to them. We know that. Safety is also about relations as well, and relationships. So sometimes children sometimes don't feel able to tell us what's happening to them until they have a relationship that they feel safe with. And that's really important as well. And that might be a friend, it might be a relative, it's a trusted person that they think they feel safe with, and that safety enables them to you know, to share information. They feel that that person will then listen, will believe them, will take action, and so on and so forth. So safety is really, really important, both physical, but probably more importantly, I would say relational safety is a key factor for children.
Okay, so the role of health in supporting children who've been sexually abused. Obviously, in my line of work, we talk about our role a lot. Health is a really diverse group of services, and I heard on the radio this morning that the NHS is made up of 160,000 small businesses or big businesses, depending on GP practices, up to the major hospitals. In this region, we've got GP practices, we've got several hospitals, we've got lots of primarily outpatient-based services like community paediatrics, we've got CAMS, and also we've got specialist services. We're really lucky in Bristol to have a big pool of specialist services we can draw on. We've got Be Safe, who work with children who exhibit harmfully sexual behaviour. We've got the SARC, where we're able to get children seen who've been sexually abused within the last 7 days. They can go and have forensic medicals there and also get a lot of support there. We've got community paediatricians on call 24/7 who can give advice for young people who've been sexually abused. And we've also got specialist clinics where we can see those young people who've been abused more than 7 days previously. We've also got Barnardo's, who run the base service, which is Barnardo's Against Sexual Exploitation. So we're very well resourced in this region. All of these different groups, they function as separately commissioned services, which means that they usually won't have access to what other services have done. So I can see community paediatric notes, but I may not be able to see the CAMS notes. So when health professionals come to meetings about young people, they'll largely be bringing the information that they hold in their service. They won't know what's been happening across the board. That's a real challenge in health, something that we're working towards, but it's not resolved yet.
And so that's why it's really important that if you want advice and guidance around children, that you're mindful of that and you know who's who, which organisation is which, and you know, make sure when we're talking about sexual abuse, you have the right people in that environment. When we were designing the pathway, it's really lovely to see it at this point actually. I remember lots of very long, difficult Zoom conversations through lockdown when we were trying to do this spread out. When we were talking about health within the pathway, it was really tricky where we put it because we have the criminal justice response, we have the children's social care response. Health straddles both, and health actually can be completely independent. Just as the welfare strands are really important, it can happen before, after, during criminal justice, when there is no charge, when there's a conviction, when there is child protection planning, when there isn't child protection planning. So the welfare and the health things are really broad, and it was really hard to try and think about how we pictorially kind of share that message really. So I'm glad it's there. What we will say about, you know, in doing the work, sometimes the health issues, people worry that, and often they're coming from a good place when they have these worries, is they think that an examination in the context of sexual abuse is going to be something that's more harmful than helpful, and therefore they think it shouldn't be done, or it should only be reserved if it's absolutely going to be evidential. So that means that often health assessments are only offered to a few children, and largely those children in whom sexual abuse may have just occurred, and there might be DNA evidence, for example. That's not we're not doing right by these children really, if that's how we kind of view it. Research doesn't support that it's a traumatic process, and when people think about recovery, they're very good at thinking about psychological well-being recovery, and therapy is what children need. But as we all know, because we're all educated in this field now, you cannot sort of pull apart the psychological from the physical. Your body and your mind are very, very linked together. So we always have to think about physical health as well as psychological health to really give children the best kind of response following sexual abuse. And the pathway does highlight this, and it kind of gives you evidence-informed guidance about what it's like. It starts with children saying about what a medical felt like to them, the kind of language that you should use, and where you can get help if you're thinking this would be a child in which there's a need here, who can I ask? And you are very well resourced in Bristol, which is great. And examinations, when they're offered by the right people, they are very trauma-informed, and one of the key factors is they allow this bodily autonomy of children and young people following a situation where they have not had that, and that in itself is often the part, one of the small pieces of recovery that are really important.
Okay. So we sometimes get families bringing their children to medicals, and we'll always introduce ourselves and ask, do you know why you've come here today? And sometimes we'll be told it's so that we can prove whether or not she's telling the truth, which really worries us because that's absolutely not the role of our medicals. The young people do come along for anogenital examinations, but that's an area that's designed to have things pass through it. So either penises, when young people choose to be voluntarily sexually active, poos, babies in the future. The area tends to heal very quickly, and it can heal leaving no scars. And we know from the evidence where people have actually confessed to what they've done that children can have normal examinations despite having repeated penetrative abuse. A lot of the abuse may also be oral or non-penetrative. So with all of those things, it means we often see a normal examination when we examine the young person. So it's really important that we tell the young people, actually, the reason that you've come for this medical today, it is our primary thing is to reassure you that everything's okay, that everything will work as it's meant to in the future. And the other thing, they see us examining them with a colposcope, which is a sort of a bright light which magnifies an image for us onto a screen. And we say, look, you can see how hard we have to look to try and work out whether we can see anything or not. If you choose not to tell anyone this has happened to you in the future, they will never know. And that's quite reassuring for a lot of the younger people. So it's really important for all the professionals who are involved with the child to be supportive of a medical taking place if that's what the child would like to happen. And the real remit is to check that they're okay and to make sure that they're physically well. It's certainly not to judge whether or not we think they're telling the truth. And the medical is only part of the bigger jigsaw of what's happened to the young person in understanding their journey. Okay. I'll give you the zapper.
Going the right way. I was nearly going to reveal Liz's age, but I won't. It's the same as mine, which is remarkable. Look, I'm just going to talk a little bit about those who have harmed sexually, and I use that broadly. I'm going to think about adults and children in about 2 minutes, which is going to be quite an achievement. But I want to think about them separately because they are separate, and one of the things we've learnt from this field of work is that it's really important to think about children and young people as children and young people and adults as adults. That sounds so logical, but the field did a lot of work drawing from adult programs and applying those to children and young people. So we often say children are not mini adults. It's not surprising, is it? But we tend to forget that sometimes. So, children, young people and adults from all walks of life engage in harmful sexual behaviour, sexually offend, whatever language, terminology can be quite challenging at times. Mostly males, but we also know that females harm sexually. So, assistant psychologist on our team recently did an audit and presented a national conference on females who have been referred to our service in Be Safe, which works with children and young people, and we've seen an increase of say 5%, say 10 years ago, to now 22% of our referrals are females, and that's starting to be replicated nationally. We also know that 1/5 to 1/3 of child sexual abuse involves children and adolescents, and that statistic's been around for as long as I have in the field, which is actually a very long time. And most contacts offences are by those known to the child or young person, and we know that from Be Safe's data. It's not strangers. Strangers do abuse. They're the ones who often hit the headlines, but it's mainly people known to children, young people, and they may be in their family, they may be peers at school, they'll be associates, cousins, step-cousins, step-brothers, sisters, and so forth. And there's been a real focus around sibling sexual abuse. I know Liz and Jane mentioned that before, and I'm glad to hear the assessment guidance is coming out. I'm also aware that AIM is also developing guidance. And sibling sexual abuse is suggested to be 3 times more common than other types of intrafamilial sexual abuse. So it's very interesting that it's only in the last 2, 3, 4 years we've really been thinking about that. So I'm really pleased that Be Safe works very collaboratively with the Greenhouse, particularly around sibling sexual abuse cases, because it's a very complex area to think about. Just thinking very briefly, I'm not going to read that definition, but it's one we often come to about what is harmful sexual behaviour. Think about behaviour that's inappropriate for age or developmental stage. Think about this concept of power over, and that could include, age, it could include developmental ability, understanding. A theme around betrayal of trust, and it can include both words, activities, it can include contact and also non-contact harm. This is just very quickly to think about sexual abuse along a continuum of behaviour from normal, developmental through to violent and aggressive, and this is often referred to, and I know Professor Simon Hackett is actually reviewing this, but it's a useful tool to help us think, and there are a range of other tools. But what I'm showing this when we think about this idea of myths is also thinking that children are sexual, they develop sexually, but we want them to develop in a healthy way. And I know that's a concept that can sometimes be difficult for adults, parents, carers and professionals to think about in that sense. We want to see age-appropriate developmental behaviour that's guided with good education and support. Just thinking about various pathways in our service, we do a lot of thinking about how has the young person got to this behaviour, what is behind the behaviour, what's the driver. And Liz highlighted the J-Time report in 2020, well worth reading. It highlighted that for many social workers, they focused on the behaviour. They didn't look behind the factors that might have been behind that behaviour, because that's where you also need to intervene. You need to intervene around the behaviour, but also the factors behind it. I think there's a tendency in mental health services, dare I say it, to focus on diagnosis and symptoms rather than looking at what's behind the behaviour. So really welcome developments around trauma-informed care, for example. Many of the young people, and I'd say the same for adults, have abuse and trauma histories. That doesn't mean you don't intervene. It doesn't mean you don't invite children, young people, adults to take responsibility, to face up, to face consequences. But we need to think about that when we work with this group. So there's a range of pathways and types of experiences of abuse. Really important to think that all sexual abuse is not the same. It's different, the dynamics, the context, the setting, nature of relationships. It might sound so obvious, but how many times have I had conversations where we tend to forget all of that? And when I'm talking about that, I'm also thinking about abuse that involves siblings, abuse that involves an older adult with a child, abuse that involves criminal sexual exploitation, criminal gangs and so forth, criminal groups. I'm also thinking about technology assisted, which we are sadly learning more and more about. There's a large conference next week focusing around technology assisted internet offences, and we're learning more and more, and we're so poorly resourced in that area. And we also know adults as well as young people, children are involved in that, and in Be Safe we're getting more and more referrals around that area. And we also need to think about peer-to-peer situations when we think about children, young people, situations in schools, but we need to come together and support, and I think we need to do a lot much more. And we know from the research that most children don't go on to become adult sex offenders. They may have other negative life courses, and Simon Hackett once again and others have done some really interesting research looking at mid-20s young people who have harmed sexually, and it's not the sexual abuse that is the concern, it's poor outcomes such as homelessness, poverty, unemployment. So it's thinking very diversely and holistically. I'm going to talk very quickly because I'm aware of time. Sorry. So I'm thinking now about, so have I missed something out? No. Child sexual abuse by adults. I have, that's gone out of order, sorry. This is just thinking about young people. I knew that had gone out of order. I don't know what's happened there. I apologise. The importance of holistic assessment, working systemically, so working with parents, carers as well as the child and young person, working with the whole system, social care, schools, key people in their lives is really important. And we need to address risks, needs as well as strengths. And I really highlight the importance of preventative approaches, and some of Professor Karen McCartan's work at UE has been really helpful, and the whole importance around thinking about child sexual abuse as a public health issue, and I would suggest crisis. Thinking about adults, not all adults are the same, various pathways, stating the obvious again. Consider histories of abuse, as I said before, and the importance of different patterns of behaviour, context, and thinking about the nature of abuse and the dynamics of abuse is really important. And this idea, and you see it in the press quite often, that all sex offenders, all adult sex offenders are paedophiles, which is actually not the case, and actually I think that's really confusing. I many years ago worked for Ray Wire Associates, and Ray developed a range of different cycles and said he used to work with social workers who would describe a paedophile to a mum, and that mum would say, that's not my husband, because it actually wasn't her husband. He had sexually abused and it needed addressing, so that becomes very confusing. So paedophile, basically, and most of you most probably know this, is somebody with a sexual interest in children, prepubescent children. So there are so we need to know about types, drivers to intervene in a way that's helpful and educate appropriately. I've taken this from the Centre of Expertise just to highlight the differences in adults, and some of that would equally apply to young people and children. And I'm not going to read through each of those, and they break that down, and once another amazing resource on the Centre's website. And yes, I did work for them on a brief 6-month secondment, which was fantastic, and maybe we can find some ways to do that again. But I think it's really useful to have that in mind when you're thinking about adults, that there are different pathways, there's different routes, and that also addresses those issues of relationships, context, setting, and so forth. Very briefly, there's limited evidence around sex offender programs, and they came into quite bad press a few years ago if people remember some of the adult-based programs. There is some evidence, and there's support for strengths-based approaches. There's also evidence to suggest low conviction rates. We know that family and community support is really important to stop reoffending, and examples of circles of support and accountability would be one example of supporting that. And prevention efforts are hampered by the belief that perpetrators are sick or noticeably different to the rest of the population. So what we're saying is we look for the monster, we look for the sick person, but actually it could be anybody, is the message. And the importance of support for primary prevention. And I'm going to pass back to Michelle.
So yeah, just me.
That was a gallop.
It was a gallop, wasn't it? So I'm just going to talk about impact in the future, really. So the impact on an individual child and siblings and family, really, really important, is the people around the child. So some of you might not work quite so much with children, but you might work very much with the parents and carers who are looking after the children. Your job is really, really, really important. The number one thing, and it's so simple, it's ridiculous, the number one thing that children need is someone who's got their back. And often that person already exists in their home around them. It might be a relative, it might be a mum, it might be a dad, it might be an aunt, it might be a professional. If they've got one trusted adult who's got their back no matter what, their outcomes will be better. So your role might be being the friend, being the support person for that adult. What a great privilege that would be, to be that person. So children and siblings and family, it's really important to consider them in the whole. The impact is different for every single child, as every single child is different. Okay, they're not the same. We know that recovery from sexual abuse is possible, and many young people go on to have happy, hopeful, fulfilling lives. It's not, it's not a morbid, hopeless destiny here that we're talking about. We're talking about a bright future for a lot of these children, and we want to make sure that we respond in the best way that we can, so that that is where they're headed. Feeling heard, being seen as a person, as an individual, and feeling hopeful. These are all things that children and young people have told us about what they want after child sexual abuse. They don't want to be the child who's been abused. They want to be Jenny, who her friends describe as sarcastic, who's got ambitions to be a tattooist and loves her dog. That's who they want to be. That's who they want to be known as. And all of that really matters to them. The response of us, the people around them, their families and the wider networks is key. Trusted adults being believed are really good predictors of better outcomes for children. So that's really important to get that right from the beginning. And we need a continuum of responses, really, from primary to secondary to tertiary, to require that address the needs of all of those harmed, as well as those who have harmed. Oh, that's a mouthful, isn't it, that sentence? So it's specialists, but it's not just specialists. We're talking about, the neighbours, the society. We're talking about the key workers, the teaching assistants. It doesn't have to be specialists who make change and respond in the way that gives us hopeful futures for children and their families. It's at all levels.